Hi, everyone, and welcome to the American Ambulance EMS podcast. I'll be your host today. I'm Dr. Patil Armenian. I'm subbing for our fearless leader, Dr. Danielle Campaign. She'll be back soon. With us today, we have our fabulous co-host, Mr. Ben Wheely from American Ambulance, and Dr. Sajin Bhakta. And back with us today is our guest co-host, Dr. Miranda Lewis, who is our director of the Central California EMS Agency, otherwise known affectionately as CCEMSA. Welcome.
Thanks. Happy to be here.
Good morning.
Hi, everyone.
Today, we're going to be talking about pain management, and the goal of initial pain management in the field isn't to completely get rid of pain, but to reduce the pain perceived by the patient to a tolerable level without causing serious side effects. In this episode, we'll discuss the pain pathways, assessment of pain, and treatment of pain. Now, it's estimated that up to 30% of EMS patients have moderate to severe pain as part of their presentation. It has also been reported that inadequate pain relief affects up to 43% of adult patients and up to 85% of pediatric patients in the pre-hospital setting. One more thing to keep in mind when addressing pain is that racial disparities do exist and have been reported in the literature. Black patients disproportionately receive less analgesics compared to other races. Now, today we're going to really get into a lot of the nitty-gritty of pain management. But first, I want to ask a question to Dr. Lewis. Why this topic and why now?
So we're releasing a pain management protocol in the Central California EMS Agency starting October 1, and we're adding a couple of medications to our formulary. So we are including IV acetaminophen and ketamine.
Great. Well, we're going to be getting into those in a lot of detail in a few minutes. But first, let's understand pain a little bit better. And Sajin, why don't you lead us through the pathophysiology of pain?
So pain, or the medical term, is nociception, which is the description of the pathways involving pain, consists mainly of four components. There's transduction, transmission, modulation, and perception. And reduction of pain is called analgesia. So I'll go through them one by one. The first is transduction. Transduction is when free nerve endings from neurons in organs receive a signal that there is some tissue damage or inflammation. And this can be superficially at the skin, or it can be deeper, involving internal organs. At this stage, analgesia can be achieved by directly blocking these nerves with local anesthetics like lidocaine or bupivacaine injected directly at the site of pain. Additionally, anti-inflammatory agents like ibuprofen or acetaminophen can be used to decrease local tissue response and inflammation, which decreases pain receptor activation. The second step is transmission. This is when the signal from that nerve ending travels to the spinal cord. This step can also be blocked with local anesthetics, usually by targeting bundles of nerves or large junction of nerves called ganglions. For example, a brachial plexus block allows injection of an anesthetic in the lower neck to block pain signals from the entire upper extremity. The third step is modulation. Several excitatory and inhibitory neurotransmitters can enhance or block the signal as it enters the spinal cord and then travels to the brain. Some analgesic agents target these neurotransmitters. This is how drugs like ketamine, clonidine, acetaminophen, gabapentin, and pregabalin work. And the last step is perception. The brain registers this signal and interprets this as pain. This is mainly how opioids work. They target opioid receptors in the brain to change our perception of pain. Now, rather than rely on only one of each of these mechanisms, recent research and data has shown a better approach is using several agents or even non-pharmacologic techniques, each acting in different ways and different sites along the pain pathway, known as multimodal analgesia. This reduces the dependence on a single medication class or mechanism of action and hopefully limiting side effects. Recently, due to increased attention to the opioid epidemic, a greater emphasis has been placed on non-opioid therapies to alleviate pain. So we're going to go through several of these classes of medications here and some of the specifics that we're going to use in our protocols.
So I'll start by talking about the huge class of medications known as NSAIDs, or non-steroidal anti-inflammatory drugs. These may not be in your local EMS protocol. Nonetheless, it's good to kind of know what's out there. So NSAIDs are common medications like ibuprofen, which is Motrin, or Advil, naproxen, which is Aleve, and then some of the more uncommon NSAIDs like diclofenac, indomethacin, meloxicam, ketorolac, and actually aspirin. Aspirin is an NSAID. These drugs inhibit the COX enzymes, which are the cyclooxygenase enzymes, which are responsible for inflammation in the body. So depending on the medication, they have variable onsets of actions, and typically the oral versions are not going to work fast enough for it to be useful in the pre-hospital setting. But one of them, we do use IV ketorolac, otherwise known as Toradol. This can start working in just a few minutes, in like 1 to 3 minutes, and it has a fairly short half-life of about 4 hours, so it wears off pretty quickly. Now, we don't carry that in our system. We use that in the hospital a fair amount, but it is a fairly well-tolerated medication. NSAIDs do have some side effects. So one of the big ones that we think about is the inhibition of platelet function. So all NSAIDs do this, and they can all cause your platelets to not work well. And so this can cause increased bleeding. Aspirin specifically binds irreversibly, therefore causing more platelet inhibition than the other NSAIDs. So because of this, aspirin usually isn't used as an anti-inflammatory pain medicine to be used round the clock. That's why it's used more in like the cardiac setting, for example. And you can definitely educate your patients about this. We all kind of dread the patient who took multiple doses of aspirin for a headache that turned out to be a head bleed, because then they have more complications because their platelets aren't working. Now, long-term use of NSAIDs can also damage the stomach mucosa, leading to ulcers, and this is also because of the inhibition of those COX enzymes. And you can also get both acute and chronic kidney injury. There's also well-documented increased risk of adverse cardiac events like MI and worsening of heart failure exacerbations with NSAID use. Now, all of the major side effects are dose and time related. So higher doses, higher frequency will lead to more adverse events. And this is very logical, because you're getting more of the medication.
Patil, I would say, one thing that we did consider was adding ketorolac to our formulary with this pain management protocol. But given all of these side effects, we decided that it would be best to hold on that for now. So that's why we don't have NSAIDs or ketorolac here.
Well, I think that's really smart, because we've seen plenty of cases of even 1 or 2 doses of ketorolac causing kidney injury or exacerbating kidney injury that's already there. And if you're picking up somebody who, let's say, has abdominal pain, they're vomiting, they're dehydrated, their kidneys have already taken a hit and you don't know it, and you give them a medication like that, that can actually throw them over the edge. So I think that was a good call. Now, the next class of medication is acetaminophen, which is really alone in its class. It's not an NSAID. It works differently, but similar to NSAIDs, it is an over-the-counter medication. Initially, the mechanism of acetaminophen was thought to be related to inhibiting COX enzymes, but now it's been shown that the metabolites of acetaminophen are also active in the brain and spinal cord and directly involved in pain modulation in those regions. So it's really doing multiple different things. The onset of action for the oral formulation is pretty quick, 10 to 60 minutes. The way I always think about it is if you have a kid that has a fever and you gave them oral acetaminophen, really within an hour, their fever is starting to come down. So it works pretty quickly orally. Now, IV is even faster. IV, within 5 to 10 minutes, they're getting significant pain relief. So the IV formulation is newer to the market. We didn't always have it, but in the last 10 years, it's become more and more available and more popular. It does last 4 to 6 hours, so that's a significant period of time. And in really high doses, it can be hepatotoxic, which means toxic to the liver, but you really have to kind of go overboard with it to have those effects. Another big class of medications are opiates and opioids. So these target specific opioid receptors in the brain to modulate pain or nociception, the perception of pain. We're going to mention 2 of the most common ones here. I just want to break down the terms opiates and opioids. Opiate means natural, so derived from the opium poppy plant. And so morphine and heroin are natural derivatives of the opium poppy plant. And then opioids are synthetically produced. So the original prototype drug in this class is morphine. The onset of action IV is 5 to 10 minutes, sometimes even less. It works pretty quickly. It can also be given IM if needed, and it will last typically 3 to 4 hours. Now, morphine can cause some histamine release. So people can get allergic type symptoms like itching, hypotension, bronchospasm. It's rare, but it is possible, and we do see this sometimes. All opiates and opioids can cause respiratory depression and altered mental status. So that is always the concern. That's why they have to be monitored so closely after getting these medications. Fentanyl is a fully synthetic derivative of morphine. It's about 100 times more potent. So whereas we dose morphine in milligram quantities, we dose fentanyl in microgram quantities. So that just kind of shows its potency. It works really quick IV. So I'm talking like 1 to 3 minutes. People are having significant relief, and it wears off faster than morphine. So this typically lasts about 1 hour and then wears off. Sometimes it wears off even faster. Interestingly, fentanyl does not cause that histamine response that we talked about with morphine. So people don't really get the itching, hypotension, kind of those things as frequently because you're not getting that histamine response. And of course, fentanyl is a very potent opioid, so always watch for respiratory depression and altered mental status after giving it. Okay, next we're going to talk about ketamine.
All right, so ketamine is a really interesting drug. So it acts primarily to block NMDA receptors in the brain, but it also interacts with opioid receptors. And it does have some sympathomimetic effects, so things like increasing heart rate, increasing blood pressure, and even has some bronchodilatory effects. And the sum effect is really dissociation, sedation, and analgesia in the brain. But those effects are really dose dependent. So at low doses, you're going to see analgesia. At higher doses, you'll see sedation and complete dissociation. And so there also will be some stimulatory effects on the cardiovascular system with that as well. So these effects are typically divided into the categories of subdissociative and dissociative, with lower doses, less than 0.5 milligrams per kilogram being a subdissociative dose. And doses greater than that can lead to dissociation, meaning that the patient is not really aware of what's happening around them. At subdissociative doses, the drug can alter the patient's perception of pain without really leading to a decrease in alertness, which is how we're going to use it in our system. So the onset of action for analgesia for ketamine, for IV, it's about a minute. IM takes less than 10 minutes, intranasal also less than 10 minutes or so, and the duration of analgesia is about 1 hour. There are some adverse reactions to consider with ketamine. The primary thing that you might see is the effects on the central nervous system. So thinking about depression of mental status, ataxia, and nystagmus, and typically you're going to see this either with higher doses or if ketamine is pushed really rapidly. When you're using dissociative doses or in overdose, you can have what's called an emergence reaction. And that's when the patient experiences extreme agitation, fear, and even some psychiatric disturbances as the drug is wearing off. We don't really expect to see this with our subdissociative or pain doses that we're going to be giving. As far as effects on the respiratory system, so with rapid administration, you can see laryngospasm or even apnea. Laryngospasm is when we have a spasm of the muscles around the vocal cords, and this can lead to a complete airway obstruction, which can be pretty scary. So we are choosing to administer this as a slow infusion rather than as a rapid push so that we can mitigate that risk. Hypersalivation and bronchorrhea can also occur with higher doses. So some of the cardiovascular effects of ketamine, we kind of already mentioned this, but it can cause an increase in heart rate and blood pressure due to those sympathomimetic effects. And this will increase myocardial oxygen demand and can precipitate a heart attack even. So we are not going to be giving this for patients with suspected cardiac pain for that reason. And then in pregnancy, ketamine stimulates the tone and frequency of uterine contractions. That could result in reduced perfusion of the fetus. So this is contraindicated in pregnancy.
I just want to reiterate that ketamine is such an interesting medication because it does so many different things at different doses. And so the doses that we are talking about for pain control are far lower than the doses that cause most of these adverse reactions that Miranda just mentioned. And it's also been discussion about using ketamine for agitated patients. This is a totally different dosing. So just keep that in mind. Totally different indications, different dosing, different side effect profiles. So it's very safe for this like analgesic use.
Yeah, thanks for pointing that out, Patil. Yeah, it's ketamine in these low doses is pretty widespread at this point. So lots of EMS agencies are using it and using it very safely. And so that's why we're trying to be really thoughtful about the doses and the rate of administration.
Yeah. Sajid, you want to talk us through some of the literature out there on pre-hospital analgesia?
Absolutely. So the first study that I wanted to talk about actually just came out earlier this year in 2024 in the Journal of Emergency Medicine. It's compared IV acetaminophen and IV ketorolac. And just wanted to use the study to highlight that in all these patients, they showed a reduction in pain by about 2 points on the numeric scale. And so a lot of people often scoff at giving, Tylenol to a patient with pain, but it does reduce pain, and it's been shown in literature to reduce pain. You don't necessarily have to jump to opioids or ketamine right away. If you do the non-pharmacologic therapies like we'll talk about, in addition to IV acetaminophen, you can get the patient pretty comfortable before they get to the hospital. The next study was also published in 2024 in JAMA Open Network Emergency Medicine. This compared ketamine to morphine for pre-hospital traumatic pain. And this was a study performed in France. Ultimately, they found that there was no significant difference in total pain reduction at 30 minutes. And the decrease in pain was about 3.5 points in each group, with slightly faster onset in the ketamine group. And they were using pretty high doses in this study, but there was fortunately no serious adverse effects requiring intervention. The last study I wanted to highlight was in pre-hospital emergency care in 2023 and looked at over 1,000 pediatric patients who received ketamine for analgesia. In this study, about 75% of patients received a single dose of ketamine, and the EMS clinician themselves reported an improvement in about 89% of the patients, and the pain scores decreased significantly from a median of 8 to 2, with 59% reporting pain score reductions of 2 or more points. So this is just to highlight that if you're not too familiar with ketamine or you're a little bit hesitant to start using it for the first time in our system, just to know that this data is out there. It's been used in other pre-hospital settings. There's good data that shows that it's equivalent to the opioids, and maybe you can spare giving an opioid in these cases, but is pretty safe at these doses. So don't hesitate. Just know that it's in your toolbox.
I love that they did this huge pediatric study because for pediatric patients, it's been shown that even getting one dose of an opioid puts them at higher risk for opioid addiction in the future, especially in the pediatric and adolescent population. So that's really useful to know that they could, in the future, have options out there that don't predispose them to this addiction more. Ben, how do we assess pain? Walk us through it.
Yeah, so there are a variety of ways to assess pain in the back of the ambulance. Obviously, each individual is going to be different, and pain is inherently subjective, so only the patient knows what they're experiencing. There are several validated tools to help us assess and respond to our patients' needs. Many things contribute to how we experience and express pain. So gender, age, education, socioeconomic status, the relative power of the participants in the conversation, so meaning EMS and our patients, and whether the person in pain is speaking in their mother tongue or another language. These all affect a patient's experience of pain. We recognize that pain is part of the human experience. Everybody's going to experience pain in some way. So we tend to assume that communicating about pain will seamlessly cross cultural boundaries, but people in pain are subject to the ways their cultures have trained them to experience and express pain. And, those cultures are not just maybe the cultures that we can visually interpret, but also like depending on where you grow up in Fresno County. In the city, you might express pain differently than somebody in an ag community out on the west side. So I just recognize that those cultures experience pain in a different way. We do have a couple ways to kind of, we'll use the phrase validate pain, and it's just basically our way of understanding of how the person is in pain. I'd say for children, it's probably a little bit easier in some ways for a paramedic or an EMT to assess their pain. We use the Wong-Baker Faces Pain Rating Scale, and you've all seen the sticker that has the different looks of pain on that little card. And it actually is pretty helpful when we're talking about kids under the age of 10, when they can't necessarily communicate with words what they're experiencing. So if the patient is smiling, they're not in pain for this patient population. We consider that a 0. A partial smile, it hurts a little bit. A neutral facial expression is going to hurt a little more. We go all the way down to a slight frown, to a full frown, to crying. Now, obviously, in that we also got to consider, I'm a stranger coming into this 3-year-old's house, and they don't like my presence there. And so are they crying because I am agitating, just my presence is agitating them? Or did that fall off the bed? Did that actually hurt? And so we do have to do a little deducing. The other way that we talk about validating pain in the pre-hospital setting is the numeric pain rating scale. This is obviously one of the primary methods of patient pain assessment, where the patient either circles or verbalizes the whole number, 0 to 10, corresponding to their pain intensity, where 0 is no pain and 10 is extreme pain. There have been high test, retest reliability and validation for acute pain for the scale reported in both literate and illiterate patients. And that's what the studies would tell you. Speaking from experience, we also know that this pain scale can get some funky results, let's say. So obviously, 0 is going to be no pain, 1 to 3 is mild pain, nagging, annoying. It doesn't really interfere with your daily life. 4 to 6 would be moderate pain, interferes significantly with your everyday life, your ability to concentrate or think. And then 7 to 10, severe pain, disabling. You are unable to go about your daily business, and you are not able to think about anything but that pain. As a paramedic, and Dr. Lewis will kind of back me up on this here locally, we do trust our clinicians to use a little bit of discretion in this. So you run back-to-back calls, and you come from compound injury following a motor vehicle collision, and that person is rating their pain at 10. And then the next call you run a stubbed toe or a hangnail, and that patient is also complaining of a 10. We get to use our brain a little bit on that one. I'm going to give ketamine to that patient who's experiencing a compound leg injury more readily than I'm going to give ketamine to somebody who has a hangnail. So do use a little bit of paramedic discretion in that assessment.
And then also like the converse, which is there are people who are so stoic and they have these awful injuries. And sometimes we have to be like, no, it's okay. Let us help you treat your pain because your bone's sticking out of your leg. That's got to hurt.
Yeah. All right. So once we've assessed the patient for their pain, we need to manage their pain effectively. So just kind of go into the specifics of it. For an extremity injury, pain management begins with immobilizing or splinting the extremity. So this is your ABCs. This is going back to the basics. We need to immobilize and splint. Immobilizing the affected limb is going to significantly reduce the patient's pain often. And then sometimes the patient will only require the application of a splint for pain management in that case. So you think about fractures, we want to be really careful about how we manipulate those, but putting something back in line safely and splinting it there might help a little bit. It also lessens the chance of neurovascular injury occurring during a transport. Lifting or elevating the immobilized extremity increases venous flow from the extremity and decreases arterial blood flow. So elevation above the heart limits tissue swelling and assists in pain control. Ideally, the extremity should be raised above the heart level. However, if this isn't possible due to logistical reasons, simply elevate the immobilized extremity onto a pillow or blanket roll for therapeutic relief. So again, above heart level is a good way to think about it. Providers sometimes overlook the application of ice or ice packs to painful areas. Cooling an injured area decreases the pain information transmitted from the nerves, thereby lowering the patient's pain perception. Ice also helps limit the amount of swelling in the injured area, and swelling will increase the tissue pressure in the area and correspondingly the amount of pain. So again, a lot of this goes back to the ABCs. Elevate the extremity above the heart level, put ice on it, and try to keep them in a calm environment yourself. Those are for extremity injuries. Obviously the unseen injuries. So if a patient's in a motor vehicle collision and maybe suffering from a broken rib, you can't necessarily see that, but we need to be mindful of that. Again, following the ABCs, considering flail chest injuries. But then that's what this pain management protocol is going to help us manage the patient's pain.
Speaking of the pain management protocol, starting October 1st, 2024, we are going to have a new pain management protocol in our Central California EMS agency. Dr. Lewis, why don't you walk us through it?
All right. So we're going to start with assessing the patient. So we're first going to determine the patient's pain score using one of those standardized pain scales. So we'll include the numeric pain scale in the protocol, along with a description of the patient's ability to function according to that scale. Additionally, we have the Wong-Baker FACES scale that Ben described earlier. So you're going to document that pain scale in your chart, along with the vital signs before each medication administration. We also want to consider putting the patient on the monitor, and that's particularly important for patients who are going to be receiving those stronger pain medications like fentanyl and ketamine. So we're going to have them on a cardiac monitor and a pulse ox. Next, we're going to consider our non-pharmacologic pain control measures. And those are the things that Ben just talked about. So placing the patient in a position of comfort, applying ice packs, splinting if indicated. So we have 3 options for pharmacologic pain control. For mild pain, so that's pain that's like a 1 to 5 on that numeric pain scale. That pain is interfering with activities, but it's not disabling. Those patients, you have the option for IV acetaminophen. And so that's going to be in adults, 1,000 milligrams over 10 minutes IV. And that's going to be in a slow infusion. In pediatric patients, it's 15 milligrams per kilogram IV over 10 minutes. And the maximum dose is going to be 1,000 milligrams. And so this doesn't mean that every patient who has pain of 1 on a 1 to 10 pain scale requires an IV and Tylenol administration. So you kind of have to use your judgment about whether, the risks and pain associated with an IV is really going to outweigh that pain that patient is experiencing. So that's just one of the options available. For pain that is moderate to severe, so we're talking about a 6 to 10 on that pain scale, and that's pain that is intolerable or disabling for the patient, we can give either fentanyl or ketamine. And there's kind of situations where fentanyl is going to be more ideal or ketamine will be more ideal, and we'll talk about those in just a second. If we're giving fentanyl, this is something that folks are probably very familiar with. So our dose there is going to be 1 microgram per kilogram. And we have a variety of routes that we can administer this, either IV, IM, IO, or intranasal. Our maximum single dose is still 100 micrograms. And if you feel like you need a repeat dose, contact base. If you're in a more rural region and you have radio failure, you can repeat that 100 microgram dose if the moderate to severe pain recurs or persists after 10 minutes. And our max cumulative dose is going to be 200 micrograms. Our dose for ketamine is going to be 0.25 milligrams per kilogram. And it's very important that we're diluting that in 100 mLs of normal saline. And we're giving that as a slow IV infusion over 10 minutes. And again, that's to mitigate some of those potential adverse reactions like respiratory depression or psychiatric disturbances. We can also give ketamine as an IM or intranasal dose. And so that dose is going to be the same. It's 0.25 milligrams per kilogram. Our maximum dose for any administration is going to be 25 milligrams. And we're doing that as just a single dose.
And I just want to jump in and say that don't give fentanyl and ketamine together without base hospital order.
Thank you. Yeah. All right. And then we've included Zofran in the protocol. And that's really, we have a protocol for Zofran in and of itself, but we want you to just consider it. Sometimes patients can experience nausea and vomiting with pain or with pain medications. So just consider that if indicated. And then once you administer the medications, go ahead and reassess the patient, document where the pain scale is after medication administration, and then include your vital signs after each medication administration. So we've got some special considerations. One is that acetaminophen can be used in addition to fentanyl and ketamine for patients who have moderate to severe pain. So there's no contraindication to giving IV Tylenol in addition to those other medications. However, remember, as Patil mentioned, fentanyl and ketamine should not be administered together. There are some contraindications to consider for both fentanyl and ketamine. So looking at fentanyl, it's contraindicated in the following conditions. We don't want to give fentanyl if the systolic blood pressure is less than 90 because there is some risk of decreasing the blood pressure. We don't want to give fentanyl if the patient is exhibiting any signs of respiratory depression because, again, we know that fentanyl can cause respiratory depression. The other contraindication for fentanyl is pregnant patients who are in active labor. We don't want to give it in that situation. And then looking at ketamine, we've got a few contraindications here as well. So we're not giving ketamine to pregnant patients at all. We're not giving ketamine in suspected cardiac pain. And remember, that's because of those sympathomimetic effects of ketamine. So no ketamine for cardiac pain. We want to avoid ketamine in patients with traumatic brain injury or GCS less than 15 because it can have some effects on the mental status. And so we don't want to give it in those situations. And then this is an important one, I think, particularly here in our region where we have a lot of methamphetamine use. We do not want to give ketamine in patients who are under the influence of methamphetamine, PCP, or other stimulant drugs because we don't want to have any additive sympathomimetic effects. And then in those patients with active psychosis, ketamine is relatively contraindicated, again, because it can have some psychiatric effects. And then a couple of other considerations. So it's important to communicate the pain medications that were administered in a verbal handoff at the receiving hospital so that we don't inadvertently give a patient an additional dose. And so we know what the patient has gotten. So you'll also want to consider your intranasal or intramuscular administration when appropriate for those patients who don't otherwise require IV access. And so you're not always going to have IV access, and that's okay. You don't have to give anything if the patient's pain is very mild. And then finally, we want to be considering lower doses of fentanyl and ketamine in geriatric patients. And that's patients really 70 years and older because they can have more side effects with those medications.
That was a great overview of this brand new protocol. I feel like there's probably going to be a few questions. So maybe let's go through some of the questions we thought of.
So Dr. Lewis, we've had a pain management protocol before. It lasted a couple years, and it was using one drug, fentanyl. Why the change? This feels like a toolkit or a toolbox of pain medication. Why are we making this change? How can I expect to see it benefit patients that I'm caring for in the back of my ambulance?
Great question, Ben. So there's a few reasons I think it's useful to have a toolkit. One is that we're in an era of drug shortages. So we're constantly seeing a shifting drug shortage of fentanyl or ketamine. It's kind of a moving target. And so having a variety of options available lets us have a backup. The other consideration is there are some situations where fentanyl is more appropriate, and there's other situations where ketamine might be more appropriate. And we talked about that a little bit. So ketamine is not appropriate for cardiac pain. However, fentanyl is a great option for that. The other consideration is that sometimes ketamine is really nice for traumatic pain. So if you've got a patient with borderline blood pressure, ketamine's a better option. The other consideration is that a lot of patients are actually afraid of receiving fentanyl now. So fentanyl is an addictive substance. Patients are afraid of that. And so having another option available to those patients is valuable. And finally, I think having that idea of multimodal pain control. So we're adding IV acetaminophen, and that's an option for patients with pain that's maybe a little bit on the milder side, but you can also use that in addition to ketamine and fentanyl as an adjunct to improve pain control.
Now, in the pain literature, there is a lot of talk about, like you mentioned, multimodal pain control, but there are some studies where they use morphine and ketamine together. And this is especially in the hospital setting. Now, why don't we want medics giving both fentanyl and ketamine together in our system? What is the rationale behind that?
We are trying to roll this out as safely as possible. This is a new medication, and as we mentioned before, there is a risk of respiratory depression with both fentanyl and ketamine. And so those effects can be additive if those medications are administered together. So in order to just be as safe as possible, we're going to stick to one agent when it comes to those medications.
Now, Sajjan, are there any special considerations with ketamine?
Just as Miranda mentioned, just be very careful with the airway and respiratory compromise or respiratory depression. Ketamine overall is relatively protective of the respiratory system, but in cases where it's given very quickly or it's mixed with other drugs, It can cause increased secretions, the laryngospasm, apnea. So those things are really important to keep in mind. And then we also, just in the back of our minds, want to remember that ketamine has a very complex effect on brain chemistry. There are several studies ongoing and have already been published about benefits in psychologic disorders such as depression. However, it can also be a psychoactive substance and it really shouldn't be used in any patients with active psychosis. It's led to concerns about use in patients with schizophrenia and can cause other psychoactive effects. So we just have to keep those in the back of our mind as well. Again, typically at the higher doses or rapid administrations, but just something as we become familiar with this drug to keep in the back of our minds.
And I'm glad you brought up the use in psychiatric disease such as depression, because that probably is where you will be hearing the most about this, like out in the news and media right now. And that's totally different topic. But again, those are also different doses, different treating regimens, different frequencies. And this is a very low dose, very one time. But even with this low dose, someone might just say like, I feel a little weird. They're not going to stop breathing. They're not going to have emergency reactions at these doses. But if they say like, oh, I feel weird, or you can warn them like, you might, you just might feel a little bit off, but it's going to work for your pain. So that's the one thing I've seen with these pain doses, but overall, very well tolerated.
So I got a question. I mean, we do have an NSAID on board. We have baby aspirin. So at no point, I'm assuming, should we ever be just adding to this protocol, right? And using our baby aspirin to treat pain. Do I have that correctly?
That's correct.
All right. Thinking of ways in which this protocol could possibly interact with other policies that we have. So we'll use fentanyl when we're pacing somebody. Should we be considering other pain medications for this? Or does this only apply to the pain management protocol, Tylenol and ketamine? How are we kind of thinking about those?
I mean, I wouldn't use ketamine if I'm pacing somebody, because that falls into the cardiac patient category in my mind. So I would tend to stick to the fentanyl for that.
So what I hear you all saying is that acetaminophen and ketamine is for a pain management protocol and for no other reason. Is that what I'm getting from the committee here?
That is correct.
Yeah, the committee says yes, that's what
All right.
what you're getting. Now, what about combining IV Tylenol or IV acetaminophen with fentanyl? Do we have any concerns about that?
No concern at all. So there's not any respiratory depression risk with Tylenol, so it's perfectly safe to combine with both fentanyl and ketamine.
Yeah, it's really a great adjunct. I'm really glad that this is being added to the repertoire. I think it's going to be really useful for people. I think we've talked about ketamine a lot, but just to like really drive the point home. So why are we not doing an IV push of ketamine? Why this infusion?
So again, that's because ketamine with rapid IV administration can lead to apnea and respiratory depression. So those are the two biggest side effects that we're trying to avoid. So apnea has been reported for as long as 30 seconds with rapid IV push ketamine. So we are opting to give it as a slow IV infusion over 10 minutes. So it should never be administered as a rapid push or as an IV push at all. It should be placed in a bag of normal saline and given over 10 minutes.
And I will add that this respiratory depression apnea thing is specific to IV ketamine being given quickly. IM ketamine does not do that at all. So if you're giving IM ketamine, you just push that in as fast as you can into the muscles.
Yeah, and I think there's also just a lower risk of those sort of adverse psychiatric unpleasant effects that patients might have with the slower administration. You're not really going to see that if it's given slowly.
Absolutely. Yeah, I think people have just seen that over and over again. So I think that diluting in that 100 ml bag is the best option. Well, I think that was a really great summary of pain management and our new pain protocol that's coming down the pipeline. Let's go around and talk about some take-home points. Sajin, you first.
I think it's important to remember that we have multiple tools in our toolbox now. We're always trying to decrease opioid use in general, but don't forget you have IV acetaminophen and now IV ketamine to use for different patient populations.
Ben.
as a person in the back of the ambulance, we're giving you new tools. And so you need to really study about how you're going to use it. But in the circumstance where you're kind of in between, where you should kind of land in the toolbox, do not hesitate to call the nearest base hospital and ask for guidance, explain the situation, say, I'm kind of curious, should I give fentanyl or ketamine in this situation? Or is it okay if I give Tylenol for this transport as opposed to fentanyl for this reason? Talk through it with a physician. And the more you do that, the more you're going to understand what medications should be used when, and you will not need to rely on base as much in the future.
Miranda.
I think I just like to hit on some of the contraindications and when to consider these medications again. So again, remember that fentanyl is really contraindicated for patients who are hypotensive with a systolic blood pressure less than 90, or if they have respiratory depression. And ketamine, you don't want to give that for suspected cardiac pain, and avoiding that in pregnancy and patients with psychiatric disorders or active psychosis, or patients who are on psychostimulant drugs.
Yeah, I agree. And my take-home point is that I'm glad that we're in an evolving system where we're adding more pain tools to our toolbox, and to just remember that it's really important to assess and treat patients' pain properly, because that is one of the things that not only matters the most to them, but they're going to remember from their experience. And so it's great to have more options and safer ways to treat their pain.